the rising rates of disruptive behaviors, anxiety, and depression in that order predated the pandemic, but as everyone was coming back, it was noted that much more. Depression and anxiety in childhood are more common than asthma.
When I think about this system that's currently set up to serve kids with asthma, it works really well. You can very quickly identify that that is what's going on with the kid, ensure that there is immediate treatment that's brought online.
Good morning. I'm Jason Hopcus with Nobody's Perfect podcast.
Incredible guest, Dr. Sandra Fritsch, who's the medical director for the Pediatric Mental Health Institute at Children's Hospital, Colorado. Dr. Fritsch is also a child psychiatrist and trained pediatrician and an incredible expert who's going to help us talk even more about the value proposition of EPSDT and how Medicaid can help us transform youth mental health. Welcome, Dr. Fritsch. Thanks for joining us today.
And thank you very much for the invitation. Greatly appreciated.
You know, Dr. Fritsch, you and I have worked together for a long time. And as a result, not only have I learned so much from you, but I have this really good understanding of how your practice in so many different states has given you a really good perspective on how other states are effectively using Medicaid and the EPSDT benefit to serve kids. Can you just give sort of a quick synopsis of how some of these other states are more effectively doing that work?
Yeah, with the caveat being that a lot of states have been struggling since the pandemic. And I moved to Colorado in 2016. So this is really a little bit more related to past times. I had the fortune of having worked in New England, in Rhode Island, Maine, New Hampshire, and Massachusetts. Massachusetts really implemented nicely the true early periodic screening aspects of things, of ensuring that there are socio-emotional assessments for well child visits at yearly visits from birth to 18 or 21, shall we say. My experience here in Colorado is our primary care providers do a wonderful job of doing developmental screening up until roughly age 3. And then there may be a gap between age 3 and age 12, where they then start to implement screening for depression, suicide, and anxiety. Lost opportunities to be able to assess where that preschooler is at with their socio-emotional growth and development. The potentially struggling school-age child, where if we can identify it early, and that's what I like part of EPSDT, having early in there, might offset the difficulties we see with comorbidity in the teenage years, might actually change Colorado's death by suicide is the number one cause of death for 10 to 24-year-olds in Colorado. What if they were screened and their mental health problems were addressed earlier? Would that number go down?
Well, and say more too, when you're saying things like early and periodic screening, I mean, not all of the people listening totally understand what to expect from that, right? So those of us who deal in this space all the time understand what that means. But, for the average parent out there, what does it mean? And how does that frame sort of what they should expect when they go into their doctor's visit when you're using those kinds of words and phrases?
I do know that screening is then really built up in a lot of people's experience with primary care, where they go in and they're handed a form to fill out or a survey to do, or, in all different domains. And, I do think that a lot of us are concerned about how can you do it in the practice with all of that components, but also fatigue from that standpoint. So there are tools or screening tools that are available that can give you a broad overview of where younger kids and teens are with respect to how are they doing in their socio-emotional health. So there's something called the SWIC, which is the Survey of Young Child. And then there's the Pediatric Symptom Checklist, which has been developed to give a kind of take a pulse on where someone is at. And are there indications that they may be having some struggles and difficulties? And if so, what further should be looked at from that standpoint? The opportunity to do this would be at those yearly well child visits to get a sense of that. I know that there are a lot of primary care practices that are also assessing for social determinants of health, and having those two indicators to know what next to go for, to help and see, are there problems that are being recognized that need to be looked at further? So that's what I believe to be the socio-emotional screening at well child visits for the EPSDT.
Right. So if I'm a parent, like I walk in and I've got my young child and I'm going in because I'm regularly scheduled. I'm having my kiddo looked at, making sure we're on track for all of those benchmarks that we need to show that my kiddo is healthy. And what I should expect is that in addition to being asked if we're meeting certain sort of height, like all those questions, that in addition, my doc should be, or my nurse practitioner should be asking questions around the social emotional. Like that's the screening tool, is really just like a series of questions that helps them understand sort of where we're at with our overall mental health with my child. And even in young children, like that really matters.
Yes, it really does matter. It also may be with our changing world of how we're doing healthcare, and with different organizations that might be on electronic health records. Sometimes families can receive an email through their quote, my chart, or whatever their electronic health connection is, asking them before the visit to fill out that kind of information. So that's one way it could happen through those well child visits, versus showing up and being asked to come 15 minutes early to complete those forms as well. And so those are ways that they can actually be implemented.
I have a question. You had mentioned earlier that there were gaps in the system, that we're doing this between like 0 and 3, and then there's some gaps. What is the major contributor to seeing those gaps in the system? I mean, it sounds like this is fraught with different failure points that could happen along the way, not necessarily anybody's fault, but what do you think is the primary driver behind some of these gaps that we're seeing?
I think it's multifactorial. Number one, it's how do we educate our primary care providers on knowing how to do this, how to have practice transformation. As I was mentioning earlier, that oftentimes things don't happen until roughly age 12, where the youth may be given the patient health questionnaire, which is an assessment for depression. And so, and that's a 9-question instrument, pretty easy to do. Most people are familiar with it. But that not understanding and knowing these other tools that can be administered each year. The other part, though, that in my work with different primary care practices that I've heard also is, what if they're positive? What do we do with positive screens? We don't have the resources available to address that, especially for younger kids. And so there's almost a don't ask, don't tell kind of, because if it reveals something, then what are the next steps? So I think that as we're asking our primary care providers this kind of work, help and support in the next steps is really important. One of my roles is being a medical director of a child psychiatry access program, where we are available to primary care providers to provide peer-to-peer support when questions come up, how they can do the work. There has to be what are the next steps, and what is the support they are given in order to be able to implement and then do the next steps also.
So I'm really hearing it takes a village, literally.
Absolutely.
A lot of the failure points are coming just in access to awareness of resources. If somebody tests positive, for needing additional support resources, and ensuring that the people that are treating our youth to begin with actually have the training and the access to the things that they would need to support somebody. Is that kind of
That's
accurate assessment?
Great, accurate summary. Absolutely. And the other part too is we have huge workforce shortage challenges. in Colorado, there are not enough child and adolescent psychiatrists. There's a severe shortage, even in the Denver metro area. I think the only state that has the right number for the population of kids is Vermont right now. But that's of child psychiatrists. That's true for other behavioral health specialists as well. So then there's that fear of, if my patients need the care, where are they going to get it?
And Dr. Fritsch, sort of along those same lines, when you're talking about the potential services that can come online after a family demonstrates that need, right? They fill out the questionnaire, they meet with their provider, the provider goes, gosh, it looks like you've got some real challenges here, and we need to line up some services to meet those challenges. Can you just give some examples of what those kinds of services are that, when this works well, could come online to better support children?
Absolutely. So I think I'm going to try to give some steps along the way.
That's great.
So the first step is what can be done in the primary care office. Looking and seeing there's a problem with anxiety or depression or disruptive behaviors, and it's in the mild to moderate category. Can that be handled by some education to the families, some materials and resources through the primary care provider? And that's why programs for the Child Psychiatry Access programs, to be able to help and support the primary care providers do that treatment in mild to moderate, is one component of it, to give that support and help people have the courage to do the work going forward. Some practices, and it varies place to place, have been able to bring on board an integrated behavioral health clinician within their primary care practice, where they are there and available for what we call warm handoffs. Like if a problem happens during the visit, that the primary care provider is able to bring the master's level licensed therapist into the visit and talk about what's going on and hand off for that care to be provided. We also have a newly emerging program called collaborative care, where it's looking at and ensuring that the patients in the practice are receiving evidence-based care in the practice. That is, there's a triad of the master's level therapist, behavioral health treatment coordinator, the primary care provider, and then a child psychiatrist or psychologist who is helping and supporting and overseeing. That's an initiative that there's a lot of enthusiasm about, but that's a work in progress due to how can it be billed. And same thing true for integrated behavioral health therapists. Being able to do that work in primary care from a billing standpoint can be a bit challenging. And then you've got the medical neighborhood notion, where the primary care is at the center, but then they have all their preferred outreach where they're going to do referrals to, which can include child mental health providers as well. And then the old traditional way is they send it off to a therapist someplace and may or may not hear back on what's going on.
Think of like a specific patient example, Dr. Fritsch. Like, think of someone recently who, you've worked with in this way. Can you just sort of give that specific example? Like, this young child presented with these kinds of needs, and then walk through exactly what happened through the lens of that patient's experience?
Yeah. So this is going to be a little bit made up, but so you've got a 4-year-old in preschool, not necessarily doing well that you would want to see happen in a preschool setting, with friendships, being able to sit and listen and things like that. So the SWIC, the survey of well-being of young child, demonstrated it needed to have some more things. The pediatric primary care provider was aware of the preschool checklist for ADHD and behavioral disorders and did that, and it came out positive. That primary care provider is thinking, okay, what are my next steps? Oh, I remember that parent management strategies are part of it. And they might not know how to have the resources, so they might call their child psychiatry access program to get a list of those resources from that standpoint. Has got some issues with running out into traffic, parent can't go to the grocery store without it being a challenge, and safety is an issue. And so the primary care provider might be thinking, well, should I consider medication, working with the family and the youth? And they then might seek some help and guidance about that from that standpoint. One primary care practice provider might have an integrated therapist in there that can work specifically with the parents around some parent management training and strategies. And so that can be ease and in there from that standpoint versus being referred for that therapist in the community.
I really love this model of collaborative approach. It's amazing that in 2025 that integrative healthcare is still something that we're talking about, a place to go versus something that should already exist. Like, based on the work that you're doing and having worked in these different models and systems, help paint the picture of improved outcomes from doing this in a more collaborative way. Like, what does that really practically look like? And is that working as designed when it really plays out the way that it's designed to?
I think most people are aware of the declaration of the child mental health emergency and crisis. And it was following the pandemic, but it predated the pandemic also. The rising rates of disruptive behaviors, anxiety, and depression in that order predated the pandemic, but as everyone was coming back, it was noted that much more. Depression and anxiety in childhood are more common than asthma. So being able to address that and treat it early on is a way to help go forward in a positive way going forward, rather than being stuck and not able to master developmental milestones we need to master. So, for example, we all have jobs in life. Say you're a 7-year-old kiddo, your job in life is first and foremost to be a student. Secondly, to have positive peer relationships. And thirdly, to be a member of the family. And we all know if things aren't going well in our job, we're not feeling too great about ourselves. So if a kiddo's got a mental health condition that's interfering with that, that's also going to impact their sense of self, their belief in themselves, and how they can go forward. So early recognition and earlier treatment, hopefully, the outcomes will be that they will successfully do well in school, have good peer relationships, avoid using substances. The other part, too, is we know that untreated behavioral health conditions can also be a risk for co-occurring disorders later on. And so can we offset that as well? So the outcomes I would be looking for would be healthier socio-emotional functioning in our kids as they move into adulthood, positive peer relationships, successful matriculation from high school, not being involved in the criminal justice system, things like that. So, but I can be kind of grandiose in my hopes also.
That's a really great way to then talk about what are the obstacles for the system working to support those kinds of things, Dr. Fritsch. I mean, when you just said child anxiety is more common than asthma, and when I think about the system that's currently set up to serve kids with asthma, works really well. Like, you can very quickly identify that is what's going on with a kid, ensure that there is immediate treatment that's brought online, that parents are given the supports that they need to know what to do. I mean, there is just not any question about where to turn to get those supports, including in the middle of the night. Like, if I'm having an asthma attack in the middle of the night, there's a phone call, there's a text, there's a resource that right away addresses. That doesn't exist for kids living with anxiety. So can you just sort of talk through what you think those barriers are? Why isn't it working on this side for kids with anxiety in the way that it's working so well with kids with asthma? What are the big challenges?
Well, I think for far too long, we have taken the head off the body. It's been, someone else's job to handle it. And rather than treating the whole person. And so part of that has been what kind of training do our professionals have, whether it be a pediatrician, family medicine doc, pediatric nurse practitioner, folks who are working in the primary care setting. What has their background and training been to do that? It's easy to learn how to use a peak flow meter, listen, and get those objective measures. The nuance, I think, involved in addressing and treating behavioral health concerns in primary care can sometimes be a barrier to being able to do that. Plus, the past lack of training and knowledge. To become a pediatrician, you after you go to medical school, you do a pediatric residency. And what happens nationally, it gets overseen by the ACGME, American College of Graduate Medical Education. That's what it stands for. They have recently now put in requirements for learning about mental health and behavioral health, both from a didactic learning, lecture standpoint, but also experience. Hopefully that will help change. Programs like the Child Psychiatry Access Programs to educate and support the primary care providers so that they've got someone they can call and learn from is another way to be able to support that work happening in primary care. We're really trying to get that going now. Currently, in the United States, 46 states have received funding from the federal government to start and implement or maintain the Child Psychiatry Access Program. There are 3 of the remaining 4 states that already have their own funding. So good news is we're building the infrastructure from that standpoint. But I think the other parts of infrastructure building that need to happen and be made more clear, part of that taking the head off the body or the head not being on the body has been the split in our insurance coverage system where there's the physical health and then there's the behavioral health side of things. And not having those blended together and not having true parity has been a challenge as well. And so there's a lot of more work that needs to happen in that realm.
When Medicaid is a partner, because you've seen it both ways over your career, what is the difference in sort of the workability of this when Medicaid is a partner in meeting mental health needs versus when it's not?
I think being a partner includes not just being a partner for the healthcare providers, but partnering with the families as well, and partnering to be able to educate what are the resources that Medicaid is supporting EPSDT for the families, for the providers, for the resources that are available, as well as ensuring that there's parity for kids compared to adults, where there can be some lack of parity for payment, but also parity from mental health and behavioral health. So it's not split off from that standpoint. Work has to happen to make that be more standard. I would love to see in Colorado that there be core standards of what services are available for kids on Medicaid, that no matter where you live, if you need home-based treatment services that are evidence-based, you can live in Lamar or live in Denver and still get that service because it is an expectation of what's going to be delivered. So I think, those are other opportunities from that standpoint as well. There are states who require that certain services happen no matter what through the state, compared to other states where different regions are given more control on what they decide they're going to do.
That's great.
It's interesting. I still go back to it's 2025 and we're having these conversations. Like, I remember having these conversations more than a decade ago. And the one thing that, and I've done a lot of work in the adult space as well as in the youth space. The thing that I always have worked with parents on, specifically parents that have adult kids, is if you can get your loved one on Medicaid, the path to care seems clearer. That it becomes a little more integrated looking than what the traditional system does. So I think there's some real value and benefit in looking at how we've done that in an adult model and then really applying that in this way with youth. And there's a lot of stigma around people being on Medicaid to begin with. And aside from that, and I can't change people's perspectives other than to educate them to recognize the path to care is clearer.
Well, and, when I was in New England, if we had a kiddo who was going to need longer term care from a mental health standpoint, we did everything we could to get them on Katie Beckett Medicaid. because that was getting them into the Medicaid where they could get the wraparound services that they need, and they could get the level of care services that they need. So that was one way, one method to get the kids on Medicaid so they could get all the services. I think the other thing that was a well-intentioned initiative that happened was the Families First Act. It was well-intended. It was there in place to try to treat kids in their home setting. And what ended up happening was a lot of services closed when the Families First Act went in place. It's the residential treatment services, other things, but they didn't build out those evidence-based home-based treatment services also. So there's been a huge gap with that, which I think has also led to some of these problems that we're seeing in 2025 as well.
I have one thing that's coming up, and correct me if I'm wrong, that you mentioned the statistic about asthma versus depression and anxiety and the prevalence of those. In the work that we've done, and we've done a tremendous amount of research and planning for the way that we serve youth and families specifically, but what we have noticed is largely different post and pre-pandemic is, I think about more than a decade ago, kids were struggling with depression or with anxiety. And today we're seeing kids that have depression and anxiety and maybe some self-harm or some maladaptive behaviors. It seems like the acuity of what kids are dealing with today is so much greater than what I recognize in years past. Is that being validated in the work that you're doing with youth?
Offside of stuff that I've done work with is looking at on kids with anxiety, what is the impact of digital technology and virtual technology in the world from that standpoint. When you see the rising incidence of from 2009 to 2019 of mental health things, you also see a huge increase in connection remotely, social media use and stuff like that. In 2005, 5% of the population in the United States was involved in social media. 5% in 2005. The parts that go along with that, though, is, increased screen time might mean you're not outside getting exercise. You might not be getting the impact of the sun on our systems telling us when to sleep. So lack of exercise, lack of good sleep also has gone along with that as well. And we know that exercise can be as powerful a treatment for depression as an antidepressant can be. So if that's not happening, if kids aren't having in-person real conversations, also, how are you learning those skills? And the other part of it too is what is happening in the online world. You got a question, you look it up. There's actually a new phrase called cyberchondria, hyperchondria on the cyber part of things. And so we don't have a lot of prospective studies going forward and looking. We just have more correlations that go along with that. But that is one correlation of the rising use of screen time and that can put some of our youth at risk as well.
I am reminded of a conversation I had with a young lady who was on the Colorado Youth Advisory Council. And I was on a call with the entire group, and this young woman reached out to me. I think she was a junior in high school in Boulder, reached out to me after and said, "Hey, can we have a follow-up conversation?" I said, "Sure." And she said, you mentioned the importance of getting sun on your head or taking a walk around the block or getting enough sleep, drinking enough water. And we built an entire campaign called Simple Steps to Support Yourself around those very things. It's been quite successful. But she said to me, "Do you know of any groups that integrate into schools that can get people to start walking together as a group?" And I thought, it's amazing to me that we're asking questions around, do we have groups to go outside and get a walk? And it really, in that moment, kind of stopped me and thought, we are so disconnected, not only from ourselves and others, but we're buried in these devices. And the fact of the matter is, by your affirmation, there are many simple, free things we can access 24/7 that can absolutely improve a mood state. Yeah. And the kids don't know that. It's alarming.
And one of the bills that passed this year in Colorado was House Bill 25-1135. And that was to require every school district to have a plan on digital technology use. And I happened to be testifying at that. And a couple of folks from 2 school districts who had already implemented that talked about how fun it was to see the kids at recess actually engaging with one another and talking, being able to interact and things like that. So I think the digital world technology has sped far faster than we have. And who knows within all of that. And this is, I know, really a side derail from what we were supposed to be talking about, but who knows what AI is going to be doing, and from a positive standpoint, but also from a risk standpoint as well. But yeah, how to take a walk together. I will tell you, during the pandemic, when we had to see everyone through telehealth, I had one day where I had 3 kids in a row that I was seeing, and they were all doing really well. And the one thing that showed up in the screen for each of them was their dog. And it was the dog that they had gotten during the pandemic. And they were out walking the dog, taking care of the dog. And again, correlation is not causation, but this dog that was promoting healthy lifestyle activities, and the kids were doing well. And I would never have known about the dogs if I hadn't have been doing telehealth either, because they just showed up in the picture.
Right. That's awesome.
Listening to you both talk about sort of the environmental construct that is really informing how many more kids are experiencing higher levels of mental health need also makes me think that we didn't have a great system to begin with, right? So we have never had a system of mental health care in this, in the state of Colorado, or really any state in this country that you go and brag about. So when you start adding on more and more kids with increasing amounts of need, it really has highlighted just how problematic this lack of systematic approaches to support those needs are. And so, Sandy, that really leads me to this next question around what should we be advocating for when it comes to Medicaid, EPSDT, what should providers be saying? This has to happen. And what should we be telling families to expect and demand for themselves when we're thinking about how this system could work, given what's, technically already in place meant to support that?
Yeah, I mean, I would hope that it would be, as I had said earlier, a coordinated system of care that has set metrics about what's being offered from an evidence-based treatment standpoint, and that it's at all levels, that there's a prevention arm to it. For then the providers, how they're educated about what kinds of resources there are from that standpoint. I mean, it can be as simple as, we know home visiting in the perinatal period can be a wonderful approach from a prevention or an identification, for example, of postpartum mood problems and things like that, which we know will impact the youth. But also then what kind of prevention resources are there that are available throughout the state that Medicaid can actually help guide and oversee from that standpoint, to the, what kind of evidence-based treatments are required to be available, offered through the Medicaid system, no matter where you live, and ensuring that fidelity is to that. But then how do we inform and educate the families and bring them on board? As Jason was talking about, having someone from the Youth Advisory Board, having families weigh in on what strategies and tools can be effective to make sure these programs are delivered in a positive way. I think the family voice is really important from that standpoint. And I think also the provider and the community voice of what they need from support for doing these models in the Medicaid setting, I think is also really important as well.
To add on to that, the work that we've done at Nobody's Perfect Community was really built upon those voices, the family members, the providers, the educators, the youth themselves. And that was validated through a lot of research and survey. But the thing that I also observed that was really interesting when we surveyed both youth and their parent or caregiver, the disconnect between how the parent saw their youth and how the youth saw themselves. So that leads me to believe that, collectively as a society, it feels like we're a pot that's about to boil over, and I think the system has traditionally assumed that people understand that there is a path and there's a clear way to get on it, and et cetera. I think that is a mistake on our part collectively as a system to assume that people know there's a path, or that they're willing to get on it, or they're going to do the things that are required of them. So we were really intentional as we built out our resource list across that continuum of care to really recognize what somebody may feel like is valuable or important to support themselves may be very different than what they need, but a step is still a step. So I think recognizing that there are places to enter these conversations at various places along the way that meets people where they are, I think is important, but recognizing that not everybody is going to take on the initiative or have the wherewithal to do the research and find the thing and do all of that. So, I think it is fraught with challenges. I am hopeful that we are moving in a different direction, but I think from an education standpoint, helping people realize there are multiple entry points into the path.
Oh, absolutely. And, I tell people all the time, being a parent's the hardest job in the world. And you think it's an apprenticeship program. You think you understand it with one, and then you get another one, and they're a completely different kettle of fish. And how do you handle that? And, and when we talk with primary care about how do you do safety planning and talk about feelings and things like that, I've heard some of our primary care providers talk about the fact the parents they're working with don't have the language to have the conversation with their child. And so I do think there's some opportunities in the primary care setting prevention standpoint to actually give parents skills about having those conversations, even with the toddler preschool age youth from that standpoint, and do it as groups so that families and parents can learn from one another as well. Because it is really, that disconnect is there. And when I give guidance about, how do you work with families around digital technology and things like that, our youth are smarter than we are, and we need to learn from them some of those tools and models also.
Well, I think this conversation today has been so rich and helpful and really demonstrates that when Medicaid and EPSDT serve as partners to providers and families, there can be this expectation that kids' needs get identified and that the resources support both providers and families to help those needs be addressed and that kids can get better. So I want to thank my partner in crime, Jason, and Dr. Fritsch for coming together today to be able to talk about this. Thank you so much.
And thank you so much for this opportunity.
It was such a pleasure. Thank you for being here, Dr. Fritsch. I really appreciate your insight.
Thanks.